So this is actually a first in literature score. So this is called as a PRISM analysis. The PRISM would be the post-primary, P for primary and RIS for risk and M for modeling. So essentially, it's a new concept, like using machine learning. So we have started using 3D risk scoring. Essentially, all the conventional risk scores, which will predict short-term and long-term mortality after a primary PCR, or for that matter, anything, have got differing variables. We have got heterogeneity in ethnicity, which is not done as much in India, that we do not have Indian risk scores, and also the weightage may change. Now, a novel concept is the 3D risk estimation. Now, what is 3D risk estimation? It's been used in finance, it's been used in biostatistics. Essentially, is that if we are treating a person, if we are doing a logistic regression analysis, we will do it on a like at the time of admission, and then we say that the 12-month mortality is so much. In that, what happens to the patient? If we are treating the patient there, what happens to the human factor in that, which can change with time? So when we talk of 3D risk estimation, it's essentially the 3 dimensions of probability, severity, which is there already. And the third one is the temporal level of control which we can achieve on the risk factors when we see initially and then we see at the 12-month. It can definitely change because we are treating the patients and they are getting control on their risk factors. So then basically, like rather than only the admission parameters that we were taken, as the most risk less scores do, 3D risk estimation will also incorporate the time dynamic behavior of the vital parameters corresponding to therapy at like a discharge, and not just a snapshot in time which is taken at the admission or when the patient is discharged. Time being the third dimension. If we see the logistic regression derived 2D risk scores, which we know, for example, the Cadillac score, they all assume the linearity over time. That is, they will jackknife the data or they will bootstrap the data. That is, if something is done initially and then they sort of project it that over the next 12 months, the same thing gets continued. Even if we do a propensity match analysis, we have an untreated and a treated variable. We think that all the untreated ones should be taken as treated. All that is a kind of a projective analysis which has a lot of assumptions. Even the Zoll primary PCI index, which is taken for the post PCI, the mortality at 1 month and at 1 year, they've all done with the regression which assumes linearity, which does not really happen in real life. So the concept of a 3D human factor comes here. That is, we along with the likelihood and the consequence that can happen, we also add time. That is the human factor if he is being treated at that point in time. So we applied machine learning along with regression analysis for predicting in real time short-term and long-term mortality in Indian patients following primary PCI. That is PRISM is the name of the score, PRISM score. And as a second step, we have validated it against the conventional risk scores, both as LR and as an ML model. So we had 619 consecutive patients who underwent a primary PCI between 2006 to 2020 from 2 sister institutions with 5 different operators, with a derivative cohort of 396 and a validation of 223. That is from 2020 to 2022. We have seen the primary endpoints of the as a CV mortality, non-fatal like arrhythmia, non-fatal reinfarction. Secondary endpoints, if the primary endpoints were met, were rehospitalization for heart failure and stroke within 1 year. In this, we have studied the demographics of the patient, the PCI details, the echoes and the lab details. And in the hospital, that is 396, 30 days, 360 patients you could follow, 6 months and 1 year with 339 patients. And then we have applied ML and LR, as I said, and then we have forward validated this model from 2020 to 2022. So when we saw the in-hospital mortality, 6-month and the 12-month mortality, this is the univariate comparing models. For those who had mortality versus those who did not have mortality, we have gone and seen like what are the p-values as 0.05 and below being significant. So we had more males, we had sugars of more than 300 as one of the prime risk factors. We had hyperlipidemia, also one of the prime risk factors, of which HDL less than 30 was seen in a lot of patients, like in terms of the 0.05 and below. We have seen that the cardiogenic shock admission was very, very likely. And of course, the CLIP class 2 or 3 and more did worse. And MAP, that is a mean arterial pressure of less than 70, did worse. Anterior wall MI with an LBBB developing also did worse. Now, the interesting thing is, as we went ahead with this was all the baseline things. So as we went ahead with this, there was definitely a truncation in the data because we could not follow all our own patients. We have also seen patients in terms of telephonic as well as their local thing if something happens there locally, because we can't follow all of them like back here. And there was also a truncation because we are treating the patients, or they get referred for a second CABG or for a PCI locally. So in terms of that, when that was also studied, in the regression analysis, we found that CLIP class more than 2 at admission, ejection fraction of less than 35, a need for intubation or a CPR at admission, the 6th point there, a systolic blood pressure of less than 90 at admission, need of inotropes for more than 3 days. We went with the vasotrope inotrope score, which is DOPA plus dobutamine plus 100 into ADRI plus 100 into noradri. It's actually calculated as that. Anterior infarction, sugars more than 300, all of them were significantly positive with a p-value of less than 0.05, quite significant of 0.001 in many cases. And with this, we got an area under curve of 0.69 in the validation cohort of 65 patients. Now this is ML analysis. This is basically like pitting all of the 35 variables against all of the 37 variables against each other, because this sees the intervariate relationship. And when that was seen, we could actually get, as I did in the HOCM model also, we could get groups of patients in which there was much better accuracy, much better negative predictive value, and of course, much better positive predictive value. But a point here to make here for me is that admission sugars more than 300 was the most significant factor for a patient, even more than LVEF, because we are taught always that LVEF is the most strong one. LVEF was actually second, because the delta, LVEF, that is a gain of it of more than 5%, was very less when the sugars were more than 300, and they tended to remain uncontrolled. Now, in hospital mortality is all of what I said. Then comes the 6-month mortality. Now, in this, I had only 37% of data available. Of course, there was an attrition, but I had studied this basically to see as to what factors are important more than the number of people who come. In this, what got excluded is that the need of CPR initially, as compared to initially, all those who died at 6 months, for example, actually what progressed is that poor sugar control still remained a very significant factor. And if the patient was admitted with a cardiogenic shock initially, it has continued to be a factor. What got excluded is the need for CPR, obviously, because the patient has survived. After that, age was no more a factor, and GPI usage was no more a factor, because it was only an acute event that had happened. After that, when I went for the 12-month, I got around 7.9% mortality. We had 47.9% of data available, of which, again, we can see that more than 300 sugars continued to be a risk factor, which added to HbA1c of more than 8%, uncontrolled hypertension, and non-compliance. So we have a completely different kind of thing now, because this gives us what we should be hitting at the initial thing, so that at 12 months we can have a better analysis, rather than applying a first month score to a 12-month score. So in terms of what we did with accuracy, we have compared it with Cadillac, with SLED-P score, with PAMI-2 score, and in all of that, PRISM ML score is much better in terms of the area under curve of ROC. So then what we can actually conclude with this is, if we have patients with acute STEMI with primary PCI, they are actually better classified with the time-dependent, time-dynamic score of 3D, which can be used with an ML analysis, which is good for both the in-hospital and 1 month, 6 month, and the 1-year mortality. The only issue with the 3D score is patient attrition. I completely agree. I plead guilty that I have only less than 50% of patients, but at least it gives us a very important risk factor which can be controlled initially, because uncontrolled risk factors, uncontrolled sugar and hypertension, continue to be a very strong risk factor, both at 6th month and at 12th month. And if we can target this to less than 200, and if we have hypertension control, they can be major contributors to an event-free status at 12 month, rather than applying the first score at 12th month. Thank you, sir.